Hello and welcome to this episode of Timeless Topics. This is part 2 in a 2-part series on the importance of universal precautions to prevent re-traumatizing those we serve and serve with. In this episode, we discuss everything from our aversion to discomfort, to stigmatizing language, to taking it back to the basics of being a human first. We're so excited you're back with us for these spicy discussions, so let's go ahead and jump back in.
It makes me think about screening or evaluation for postpartum depression or anxiety or social determinants of health screening and the things that, we all know are recommended. But then the question has to come on who's doing the screening? As you said, Jessi, who's protecting these results? There was one study that I had read not too long ago that was looking at documentation and the medical charts. And it was specifically in the NICU, right? And it was talking about depending upon the social commentary that was added, whether or not the chart was seen as negative, positive, neutral, etc. And kind of their overarching recommendation was that maybe the social commentary is better left to the people whose responsibility that is, right? And not necessarily ours as the bedside clinicians, which I don't know, it sometimes gives me pause, right? Because there are some things that I really do wish I knew, and maybe I could be helpful. But then there are other things that I'm like, I don't need to know that. Um, many moons ago, there used to be an affiliated diagnosis with adolescent parent, single parent. And I remember having a tiny temper tantrum because I was like, how does being a single parent impact this baby's medical care, right? Maybe it impacts the social support that this family has, but medically, I don't think I need to know that, right? Adolescent parent, again, I don't think I need to know that. I need to know the labs. I need to know whether or not there are additional risk for any medical complications, but the rest of it, how is that going to change my management of this baby's respiratory distress syndrome? Because it will not, because that should be managed based upon the radiographic appearance, the blood gas, FiO2 requirement, the work of breathing, etc. Right? And so but I remember having this conversation and this dialogue of like, whoa, I think now we've gone too far. And like I said, I don't know where that balance is. I am not proclaiming to know any of the answers. It's just one of those situations that you sit back and say, yeah, I don't think I needed to know that. But now you have said that to me, and now I know that, right? And when we think about the aspect of implicit bias, call it for what it is, real discrimination, right? As a family member, as a parent, as now a grandparent, because I just had this conversation with someone. If I walk in the room and I feel like someone is judging me before I can even open my mouth, but you're judging me based upon what you heard, maybe even what you read, some situations, what you see. I'm not going to be honest with you. I'm not going to share. So if you ask me, do I have running water? I already feel like you're judging me. I'm going to say, yep, sure do. Right? Even if I know that I have nothing and that maybe there's some assistance out there for me, I'm not going to admit that to you because you're already thinking that I am less than, right? I'm already fearful that you're going to try to take my child, call child protective services, whatever, put me in some type of a system. Now, I'm not going to tell you anything. And again, I don't know how to overcome any of this. It's just the nature of what, unfortunately, we deal with.
I have a colleague who is doing this work in the OB and perinatal spaces, Veronica Barcelona out of Colombia. And she's doing this work about stigmatizing language in OB records. And she's currently working on a neonatal arm, which I'm very excited about. And it talks about what are we putting in these charts that then are now legal records of someone's existence, right? And their episodic experience in this space that now have hold weight, whether they should or not, right? Because am I qualified to do any of this assessment? Half the time, not, right? I'm just putting things in there. Even honestly, things like direct quotes. If they're not helpful without full context, they really don't belong there. Because without the full context and the understanding, someone else can pick that up and use it against someone. And we know that specifically Black and brown people are more likely to be targeted by CPS and things like that and have their babies taken away for similar circumstances that other people have experienced. But it's the way in which we're documenting and the way that we're codifying and like reinforcing the bias, even though technically no inappropriate words were used, right? But it's the title in which we say these words and the authority with which we've been given, both legally and from community standards, right? And so it's understanding when is the best thing for me to just shut up? Like, when do I not need to put it in the medical record? Because sometimes, like you said, there are things where you're like, that context would be helpful because then we could have XYZ helped or changed this one and individualized a little bit different, right? But sometimes you see things and you're like, oh, this is wild. No one, you don't put that in a record. You know, like I'll do a chart review sometimes and I'll have to go to people and be like, ma'am, please, no, don't do that. And they're like, what? Well, that's what happened. And I'm like, okay, but imagine reading this with no prior knowledge and a bias against this person based on whatever statistical, personal belief, whatever you want to call it, right? Imagine what could happen with the power of these words. Well, I didn't think of it that way because you have the privilege to not have to think of it that way.
I was gonna say now, even with the fact that, with open medical records, right? Read it as if it was someone talking about you. And how does that make you feel? Right? And I think if we again could put ourselves in other shoes, we would stop, hopefully, and think a little bit more and say, oh, maybe I could have used a slightly different word, right? I think my biggest pet peeve is the term difficult parent or difficult family, right? And I was like, oh, that one just really grates me because I don't know of anyone who wakes up in the morning and gets out of bed and says, I think I'm going to be difficult today. Although sometimes I do, right? But I usually admit that that's what I'm doing. And I will say, you know what? I'm just going to be difficult today. So I'm just going to call it for what it is.
I think we're all on the same vein, and I can feel myself getting all agitated about this topic because I think at the end of the day, what it feels like we're calling out is just this pervasive bias that has been enabled and allowed to perpetuate for eons. And we think we're doing some interventions because we can check off a box because everyone has to sit in front of a computer and, do a multiple choice quiz on how to not be biased at work. And so we can just say, hey, look, everybody got 100%. We have got 100% unbiased staff working. But the proof is in the pudding. And what we know, and a really excellent paper that I believe is 2025, I think, from Freeman out of the Beth Israel right down the street here in Boston. And they really looked at and I'm paraphrasing, okay? So if Freeman guys are listening, cut me some slack, but totally love the paper. And what they really call out is that, that type of what's it, CBT approach, individualized approach to unbiasing a system is a bunch of malarkey. It absolutely doesn't work. That you really need to have a cohesive cultural investment and engagement in beginning to see with many eyes, not just my eyes, which only see this, but many eyes that can see all of the different ways that bias plays out in the day-to-day minutes and moments that families and babies and patients and clinicians encounter the space in which they find themselves. And so I think, instead of us just putting a band-aid on this sunken chest wound, we really need to make sure that we are helping people navigate, well, recognize bias, right? And begin to notice that, gee willikers, maybe I'm a little bit biased, But when I'm in an echo chamber, it doesn't sound so fretful, you know? I mean, if I'm the one that's saying I might have biases, but nobody's in the room to counter that, maybe I don't have biases. Maybe everything's okay. And we've made it such a taboo thing that we don't talk about this in general in open spaces where we can actually, kind of come together and say maybe there's an opportunity for us to do better. We just continue to squeeze it out into the, little nooks and crannies in the spaces so nobody will notice, but in fact people do notice profoundly. It's palpable in the silence of it. It is so palpable. And so why isn't this part of, undergraduate education and preparation for stepping into these human service professions? Whether it's healthcare, whether it's education, whether it's, I mean, I'm going to give social workers a big, broad brush because this is like their day-to-day thing. But I think for us, in healthcare in particular, um, and particularly the way our healthcare is demographically structured, where the majority of people that are running the show and driving the car don't look like all the people that they're serving. There's just so much opportunity to be biased, right? To marginalize and diminish, what other people are navigating in any given moment, and we're not paying attention to it. And if in truth we have sworn an oath to first do no harm, that feels like the first harm. Coming out of the gate, I'm not even near your disease. I'm not even near your gallbladder. It's you walking in my door, and I'm already crafting up different ways unconsciously to harm you. And I don't want to sound, like a jerk or anything, but that's the place where I find myself right now. Outraged and frustrated that this has been swept under the carpet for so long. There are people doing great work, in many different pockets on the planet. But we need to like gather them all up, right? And like the last time we had a call, we were talking about a quilt. We need to, stitch these folks into the quilt because this is just so fundamental to everything that we do after we meet that person. Because everything happens right there, right? I'm not even touching you, but I'm seeing you. I'm seeing the people that you're with. I'm already responding, and responding is not the right word because that makes me think that you've had some intention and we're reacting. So there you go. That's my two.
Well, and I can, well, no, and I can add to that, Mary, and say that just as the provider is seeing and recognizing and whatever, the family, the patient, they're seeing that body language, right?
Yeah.
The time that I had I don't even want to. It was a PA. We'll go with it. A PA who walked in the room and picked up my purse with like two fingers and moved it from where it was sitting, right? Immediately, I was able to recognize, oh, okay, then. Is that I think we also need to recognize that a lot of times, I think, just my opinion, when people hear bias, implicit bias, discrimination, they think black, brown, white. They
Mhm.
think race, they think ethnicity. But there are so many other areas where we demonstrate our bias, where it is obvious that certain populations are not being treated the same.
Yep.
Now, a lot of our data is on our race and ethnicity, right? And so we cannot discredit that by any means. But I almost feel like sometimes if we had more of a focus on how it impacts more than just race and ethnicity, maybe there would actually be more change,
Mm.
right? Because all too often people say, ha, ha, that's not me. That's not my family. Doesn't affect me,
Yep.
right? Without recognizing that if you really went down the rabbit hole
Yeah.
and thought about all the ways that people are discriminated against, that bias rears its ugly head, you'll probably find at least one family member of yours that fits that definition. So now, oh, look, it does impact you. It does impact your family. Maybe now you should care. Is that the right thing? No, we should care no matter what, right? But sometimes I do wonder if until people have had to walk the walk, it's really easy to turn your head and say, that's unfortunate, and keep it moving.
Yeah.
Yeah, it's why when I share my NICU experience, like I do it with a hefty dose of bias discussion, but I also share it because on paper, I should not have had a traumatic experience. If you're looking at it from a, clinical lens, right, of someone who's not well versed in this work, even though we know that all parental infant separation is inherently traumatic. So, like, everybody has some aspect of it, but we tend to gloss over that, right? And on paper, it was, but you get this, you know what she needs. I do. I cognitively am very aware of the care that she needs because I just taught a lecture on it yesterday. So I understand what she needs. But that doesn't mean that I'm not impacted by this system that you guys have built here. And I don't even mean you guys as you individual practitioners, but just like this broad spectrum that we all have to practice in. I'll never forget one of the nurses was like, I just feel like there's a wall between you and us. And I was like, well, it's because there is, ma'am. Like, ding, 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 we have a winner. Like, there absolutely is a wall. I am not the one who built it, though. And she was just so shocked that I wasn't just going to bleed my heart open and dry for everything to make her feel better. Like at the end of the day, by this point in my daughter's stay, she was coasting. She just needed to figure out how to eat. I wanted to go home desperately,
Yeah.
but she would figure it out. And I knew that, right? So, like, it wasn't even like you needed this data clinically. Like, she was, for all intents and purposes, another 34-week person to you. So this doesn't change what you need to know. You just feel entitled
Yeah.
to me because now we're in this dynamic where we are no longer equals. And it made her very uncomfortable the way I chose to answer that question. But I am hoping that she was able to learn from that and figure out how can she take that to other patient populations, because I at least had the privilege of being able to say things in some ways that other parents couldn't have even gotten close to without being labeled quicker than I did, or had labels that were more impactful than mine. Because I was like, go ahead, say it. I'm difficult. That's fine. I'm okay with that. And I was like, but y'all gonna do right by my baby because there are no other options.
Yeah.
She's the most important patient I've ever seen. And I want you to think of it the same because that's how I treated every baby I ever cared for.
I I like that you brought up the challenge, I guess I'm gonna say, when people feel like is it umbrage or is it hubris, that like you should be grateful that I am here taking care of your baby. That don't give me any of your grief because I'm doing the good work and you should be grateful. And I struggle to really try and figure out where the heck does that come from? That it's such a dismissiveness of the other person, that this experience, even the patient's not important, right? It's all about you, the savior, who's like, here I am, and just bring me some cookies and we'll be good, kind of a thing. And I've seen that in my clinical experience, and never really noticed it like from a, how you see things kind of unfolding. You're like, well, that's kind of weird. You know what I mean? But you don't address it. You don't call it out because you're just kind of like, I don't even know what that is. And then, you kind of grow and you get introduced to a variety of different really wise people who help you see a little bit behind the curtain of what that means. But it still doesn't help me really understand, where does that come from, particularly in a profession like nursing. Um, it feels like like the what do you call it? Like the dark side of some benevolent uh, virtue or value, but then the shadow side is, but you better be grateful. I'm here to serve you, and you better be grateful. Am I making sense as I say that?
Well, it's almost the sense, right? Like you've heard people say that there, at least maybe it's just me. I've heard people say that I chose the profession that I chose, i.e., nursing, because I wanted to fix everybody, right? And so then it has to make you stop and think that we take it full circle back to our childhood and our ACEs, right? And so maybe for some people, so much has happened in their life that they didn't even realize it has now set them on this path where I have to fix it because nobody fixed it for me or whatever, right? But well, not still not smart enough to have all of that psychological aspect under my realm. That's why I'm not a psych mental health NP. But it does make you stop and think, right? Because the other component of what I heard you say, Jessi, was the sense of, there's this wall. And it always amazes me when people are upset when families won't talk to them, right? And it's like, oh, they wouldn't talk to me instead of being grateful that there was somebody that they did want to talk to. And then being the person that they talk to, then having that weight of, oh my gosh, they told me all this. Like now how can I help them? Do I share? Who do I share it with? Because I don't want it to get back to the wrong person. And then it's a vicious
Yeah.
cycle, right? It just becomes this sense of I want to help you, but that means that I have to tell part of your story, right? And then I have to figure out who do I share that story with? Because if I share it with Bob, Bob is going to go tell Sue, and then Sue's going to tell Jack. And before you know it, the whole unit's going to know your story. When
Right.
in actuality, I just needed to tell Tom because Tom says, cool, bet, got you.
Yeah.
This is now what we need to do for this family, right? But I think that weight is powerful and very heavy sometimes, especially Mary, as you were talking about having situations where our providers, our caregivers don't always look like our patients, right? And so when you're in that setting and you find someone who does, and they kind of latch onto you,
Yeah.
it's heavy, right? Because you then feel the weight of, right? I think in some of the literature they talk about the minority tax and you feeling the weight of, okay, well, I'm carrying all of us, right? Here I go. Let me forge into this space where I am the representative for everyone who looks like me because I'm the only one here.
But it's like you said, it's not just the black white of it all, right? Like it's whether it's someone who identifies outside of the heteronormative, dynamic, whether it's someone who speaks a different language, whether it's someone who is maybe transgender, has different gender expression, like whatever that thing that makes them see each other in is a gift, but it can also be really heavy because now you're somehow the whisperer for that family rather than realizing maybe everybody else needs to educate themselves and better themselves so that everyone can access and provide safety for this family and it doesn't all have to weigh on this one particular person's shoulders. I'm grateful that this person is there. I'm grateful that it was there. I mean, Lauren carried me through my stay, right? She truly did. And I'm grateful every single day for that woman and I love her dearly, right? But I also felt bad that she had to bear the brunt of this because this is a lot. I am a lot and I know that. Okay. And I feel terrible for her sometimes that she had to navigate things for me. But it was also just like, okay, but what can we learn from this? Are we just going to learn that Jesse's crazy? Because that's the cheapest way to get out of this, right? Like perhaps we need to take a little bit and reflect and think, not all of it hit for me, but that part though, that I think is something that I could take and do into my practice and adjust my practice because that's what we're all here for. Whether you're learning tricks on how to put in an IV or putting in a pick or intubating somebody or how to have a conversation, you're all learning and watching from each other so that you can then add to your little magic toolbox that you can pull out when you need a tool that you don't use frequently, but you saw somebody use it once. And you're like, I'm going to try that. And the more we expose ourselves to the way people live and what their lived experiences are, good, bad, and ugly, then we're able to bring it in and add to our own repertoire. So we're building this catalog of experience that we can, pull from rather than being so rigid into only what we already know. How boring is that to live a life in an echo chamber talking to only people that are going to validate your existence? We need to be challenged. That's how we better ourselves. That's how we grow.
Yeah. I think you're calling out really kind of the imbalance in the core competencies that are expected of professionals in this environment. That we obsess, and I'm not saying one is more important than the other, they are all equally important. It is wicked important to have the technical skills to be able to do X, Y, and Z. It is wicked important to be able to have the skills around differential diagnoses and calculations and all of those other kinds of things. And it is equally as important to have the skills and competence to be respectful, compassionate, understanding, unbiased, and all of the other things in any environment when you're interacting with humans in general, and particularly humans who are in crisis. But we don't, right? I mean, how many times, even if you just look at developmental care, which seems like the least um, disruptive thing that you could do in any environment, and people would just get all bent out of shape if you were suggesting putting a gel pillow under somebody's little head while they're trying to save a life, And I mean, just do you know what I mean? Like we get um, what's the word? Visceral about anything that has anything to do with being human, being loving, being, we would call it soft, or what the fluffy stuff. That was the term that we would use, the fluffy stuff. And the fluffy stuff is being human. Isn't that horrible that we have evolved, air quotes here, to a place where our humanity is an afterthought. It's fluffy stuff, and it just seems so disparate, just so incongruous with what we have been charged to do, what we have sworn an oath to do, is do no harm. And how about, like, I won't do harm to your cerebral vasculature, I won't do harm to your pulmonary vasculature, and hey, while we're at it, how about I just don't do harm to your whole self? Crazy. It's crazy.
But Mary, wouldn't that be something if that's the answer to our disparate outcomes, right? We need to go back to the fluffy stuff. And maybe that's it, right? We've been spending all of this time, energy, and money trying to figure out how to fix it, and we just need to go back to being humans.
I
Wow.
think it's worth a shot, Trace. What do you think?
Right? Maybe we could
I
all
could go
retire early. We figured it out. We've cured the world. And just be
I could go on an anti-capitalist rant, but that's really going to take us left field from here because capitalism is why we are like this. Venture capitalists and the need to make money and to commodify healing and healthcare is why we're like this, right? We have been drilled
Yeah,
down to how much money we can make somebody, and
yep.
it's somebody that we'll ever even know or need or be even remotely in the same income bracket with. So we've dehumanized and lost
Mm-hmm.
our own, the
Mm-hmm.
art of medicine to
Mm-hmm.
make somebody a dollar, you know?
Yep.
And
Yep.
it's sad because somebody's baby is stuck in the middle.
Yeah.
Somebody's grandmother, somebody's auntie, somebody's self is stuck in the middle between somebody trying to make money and somebody trying to make a difference. But we can no longer, it's not easy to do that anymore.
Yeah, I think we fixed the world. We can fix the world.
Yeah.
It's so simple though. Like, but we always overcomplicate things. You know what I mean?
Right.
Like, we always just want to say, but what if, but what if, but what if? But my answer to that is always, but what if? Like, but if what
Mm-hmm.
ifs work on your side, what if they work for me too?
Yeah.
Right?
Right.
Let's just try it and let's see where it
Right.
goes.
Yeah.
Right?
Right.
Because, and honestly, my way's cheaper. Right? So let's give
Mm-hmm.
it a shot. I'll save you a couple dollars. Right? So you don't have to
Mm-hmm.
buy this blah, 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 special fanciful, whatever thing that they're, trying to sell you in healthcare these days. Right? 'Cause I feel
Yep.
like you turn around and they're like, there's a new program for this. And you're like, does it talk to the program that does this? They're like, of course not. And you're like, okay, then why do I need that? Like, I don't
Right.
understand. Um, but it's like give it a shot.
Yeah.
Just try
Right.
being a person,
Yeah.
you
Right.
know, and see what happens. Because I bet we would be surprised as to how it would go.
You've got
Well,
plenty of
somebody,
opportunities to practice.
right? Right.
So
Well,
many.
somebody said something to me yesterday about the fact that they had heard that I talked to the babies. And I was like, yeah, is that wrong? I mean, because in my mind, some of the babies that we encounter will have very minimal kind words spoken to them in their life. Some of them are going to go into situations that we wouldn't wish on our worst enemy, right? And so, if me saying to them, the moment that they open their eyes, good morning, happy birthday, today's a great day to be born. If
Hmm.
some tiny bit of that hits their psyche, then I've done good in the world, right? And I was like, and it doesn't hurt anybody else for me to talk to them. Like, I would carry on a whole conversation, right? And people are sitting there staring at me, and I was like, I mean, it maybe just makes me feel good, but I have to hope that on some level it makes this baby feel good too, right? And I would hope that as a parent, if you walked in the door and you saw me talking to your child, it would make you feel good too, to know that I am being a human, that I am not just checking the box that I did this exam. I am, because I did the exam. But in the same respect, good morning, little one. I hope you slept well last night. Did you have a good night? Right? Like, tell me all about it. Right. And so, but I was just like, is that wrong? Did I talk to the babies? Right? Because to me, it just feels right.
Yeah, because they're humans who
Right.
need
Right?
another human to attune to them in a moment of need.
Yes.
So, no, you're
Yes.
doing 100% the right thing. We brought up the Harvard studies before about serve and return and all of that, right? The language nutrition kind of aspect of it, of that they do need to see that they're being communicated with, not just
Right.
to or about, but with. Because any NICU nurse that's been here longer than 5 minutes will tell you they absolutely do communicate with more than just the monitors, right? And so
Yes.
if you're listening and you're watching, you can have a whole conversation with that little 30-week person. I do it all the
Sure
time.
can.
And even in
Absolutely.
my own NICU stay, people would be like, you come in here and you say good morning to her and she like recognizes you. Well, imagine
That's
that. I grew
good.
her in my body. Like, of course she recognizes me.
Mhm.
And I'm here every day, all day. So when I go up to the bed and I say, hey, good morning, Ladybug, it's mommy, she knows who it is.
Yeah.
That's
And
right.
like she turns and calmly looks and will some, give one of those little gas smiles and, all the things. Like there is a moment of attunement there because she's reaching out for somebody or being interacted with by somebody, but then she's comforted by the fact that, like, oh, but I know that lady. Okay, so she's going to be good to me, right? Versus we're all going to hopefully be good to them. I don't believe that, 99% of the people, show up to work with the intent to do something good, right? I don't believe anybody is showing up with harm outside of the catastrophic episodes, right? But you are filling in that neuronal connection for the baby so that they know when I seek out and need help, someone is there to reciprocate and respond to me and say, I got you. I know this is scary. Blood pressure cuffs they suck. Don't we have better technology? Like, I mean, we have art lines, but that's a whole other thing that you don't really need right now. So, like, we just got to get through this non invasive blood pressure cuff, baby. But I know it sucks. So, let me hold your leg and I'm going to talk to you calmly about it. And we're going to get through this 45 seconds together. And then they do it,
Yeah.
because they're like, I'm not alone. I don't have to sit here and just wonder when is the thing going to stop squeezing my leg because somebody's here to talk me through it.
Yeah. I think what you're really highlighting is just our general tendency, societally, potentially globally, to depersonalize or negate rather the personhood of babies in general, healthy babies and sick babies. Um, Generally, babies are seen as accessories, that we don't really acknowledge them as a fellow human being. And that's been perpetuated through, for generations, right? I mean, children should be seen and not heard, all of those other types of things that and how we view and even how we refer to babies sometimes using the it pronoun. And so and particularly special babies, right? That don't look like the Gerber baby, so these little tiny premature individuals, or even the medicalized newborn, term newborn, because of all the medical accessories, it distances us even further, I think, from seeing them as a person. But when our baseline is already not to do that, it's not a far throw to completely depersonalize them and dehumanize them, actually. So I think that's a challenge, and kudos to you, Tracey, for for having those conversations just as well, and particularly those conversations that are witnessed by your colleagues, because it can feel clunky. If you're the only person having a conversation with a baby in an incubator, people are going to be like, what? But they're also, just by noticing you, you know, there's stuff going on in their head. They're thinking about what you're doing, why you're doing. They may, kind of shove it into like a little, closet in the back of their brain and go, Tracy's a nut, or maybe they may say, that looked kind of nice. I wonder if I have the courage to defy the status quo in this space and have a conversation with a tiny person who nobody really pays any attention to. So, I think it's one of those things where, for me, never underestimate the power of being a role model and showing up in the way that makes you feel like this is who I am. This is the best that I can do. I am doing no harm. I am respecting and honoring the full-on humanity of this microscopic human being who's hooked up to, all these different machines and stuff. And I'm going to say, hey, good morning. Good morning, honey. My name's Mary and I'm your nurse for the day. Woohoo! Let's get this party started. Because I think when you do that, you're hearing yourself. And that makes me act less inhumane. When I'm talking to you as a fellow human being, it makes me less, what do you call it? Like, I'm less inclined to flip and strip you during a do-up because I'm talking to you, and I generally don't flip and strip people that I'm having a conversation with. Do you know what I mean? Like, it's just really kind of, again, it's the fluffy stuff. It's the human stuff that not only helps the other person, but it also helps us step into a better version of the human that showed up to work today, I think.
Telling you, that's how we fix the world.
Yeah, I mean, look, we did it. We're done. Okay. We're like, what, 14, 15 episodes? We did it. You're welcome, everybody.
Yep, exactly.
I commonly will tell people that if babies could fill out HCAP surveys, we'd all be screwed.
Oh my gosh.
And it's just recognizing that, like, they're a person too, right? So if we treat them the same way that we would treat any other human being or that we would expect to be treated ourselves in an age appropriate manner, they will also be happier and they'll be kinder to you. Your shift will be easier. Kind of echoing back to that earlier point of even just from a selfish place, right? Of if this makes my life easier, then maybe this is what we should do, right? Because if we're supporting the wholeness of this child and then the wholeness of the family or community that they're attached to, then we're going to have a better outcome than when I'm only slicing them surgically into tiny little boxes that I'm going to address right now.
Yeah.
Thank you for joining us for this episode of Timeless Topics. We welcome your feedback and suggestions, so please reach out. Our handle on all social media platforms is @TimelessTopicsNICU, and our email address is timelesstopicsnicu@gmail.com. See you next time.